Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Alex Lutz, the VP of Marketing at RUMC, as well as Dr. Loren Harris, who is the Chair of Surgery at RUMC, and Dan Ryan, the Advertising Director at the Staten Island Advance. Welcome.
Thanks. Thank you.
Through RUMC Connections, you will meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. The Department of Surgery at Richmond University Medical Center has a long tradition of providing superior surgical services for the community. RUMC's team of surgeons, many of them board certified, perform comprehensive general and subspecialty surgeries. Over 10,000 surgical procedures a year are performed at RUMC in both an ambulatory and inpatient basis. The hospital has 11 operating suites equipped with the latest technology, including the Vinci Robotic surgical system, which allows surgeons to treat patients more effectively and accurately, resulting in fewer complications and faster recovery times. So like I said, today we are joined by Dr. Loren Harris, the Chair of the Department of Surgery at Richmond University Medical Center. Dr. Harris received his medical degree from the New York University School of Medicine in 1987, where he graduated in the top 10% of his class and was elected to the Alpha Omega Alpha Medical Honor Society. He then completed his training in general and cardiothoracic surgery at New York University Medical Center and has been in clinical practice for over 20 years. Dr. Harris specializes in minimally invasive surgery using the latest robotic techniques for both benign and malignant diseases of the lung, esophagus, and mediastinum, which reduce post-operative pain and hospital stay while improving overall outcomes. Welcome, Dr. Harris, and thanks for joining us.
Thank you.
So when people hear the term robotic surgery, it sounds futuristic, but in fact, it's been around for quite some time, correct?
Yes.
Yes. So it's not something that is, say, unique to just hospitals in Manhattan, right?
No, not at all. I mean, robotics has pretty much become a worldwide phenomenon. Mm-hmm. The idea was first born from the military. The military were trying to develop a platform whereby a surgeon in one location could actually perform surgery on someone in another location. So the whole idea of robotics really was formulated through that. But the actual platform, the use of robotics has really developed over time. And it started out with only certain procedures were being done robotically. But now it's pretty much throughout all of surgery, not just urology and obstetrics and gynecology, general surgery, thoracic surgery, even the ear, nose, and throat surgeons are using it for certain procedures. It's pretty much become ubiquitous throughout surgery and is really kind of the next step forward for surgery in general.
So it's revolutionized, obviously, surgery from your standpoint as the surgeon.
Yes.
And how has that helped improve patient outcomes?
Well, the minimally invasive aspect of surgery was born back in the 80s. The advancement, really, of laparoscopy. Laparoscopy actually was first introduced at the beginning of the 20th century. But the advancement of the technology, the use of laparoscopy really grew. And in the 80s and 90s, general surgeons started using it more and more. Everybody has heard about laparoscopic cholecystectomies and various other laparoscopic procedures. The whole idea was to see if we could do it and then see if we could do it safely, obviously, but and then look at the actual results. Well, it turned out that for almost every operation it was done for, patients had less pain. They had earlier return to normal activity, decreased length of stays. So all of these things led to reduced cost for operations. Patients didn't have to be in the hospital with all the things that can come with a long, prolonged hospital stay. So it became financially beneficial to hospitals to promote this, and it actually turned out that it was literally much better for the patient. Mm-hmm. And when it came to surgery, certainly in my field, which is thoracic, mm-hmm. The whole idea was, well, could you do an accepted cancer operation using minimally invasive techniques and do it safely? Well, the answer was yes, you could. And people began doing it, and obviously the techniques advanced. And then they said, well, okay, you can do it, and you can do it safely. But cancer is different than taking out someone's gallbladder. So the next question was, what is their survival? Does it affect survival to do minimally invasive lung surgery versus the standard lung surgery, which is done through something called a thoracotomy? And the answer there was yes. And in fact, the data is now becoming fairly well known and accepted that minimally invasive techniques actually can improve cancer survival in certain cancers, because we know that patients who have minimally invasive lung resections actually have a higher chance of completing postoperative chemotherapy should they need it. And stage for stage, it seems that videoscopic surgeries actually have a better long-term outcome than patients who were operated on using the open techniques. So the next step was robotics. And as the technology improved, the original iterations of the robot weren't as user-friendly for thoracic cases, but they were doing them safely. And now with the latest iteration, these operations are much more user-friendly. Patients are in and out of the OR. I would say about the same as videoscopic, but in many cases faster. And they're out of the hospital quicker. Patients have less pain. They're back to work. And the head-to-head comparisons of videoscopic and robotics in terms of the ability to do them and do them safely have been equivalent. People argue about how many lymph nodes are being taken with VATS versus robot, but for the most part, it's pretty much a wash. I mean, they're felt to be equivalent.
And the Da Vinci system is pretty top of the line, correct?
Yes. Well, Da Vinci, at the present time, Da Vinci is the only company who presently has a platform that's FDA approved in hospitals and being used. There are other companies developing them, not only in the United States and Canada and other countries, but they haven't come to market yet. I think that will actually make things better, because competition always makes things better. And that helps to advance the technology and makes things safer and better to use. But the intuitive platform has developed and has matured, and the most recent iteration of the robot is actually a pleasure to use. The instruments are smaller, so the incisions are that much smaller. So it's really it's striking. And for me, since my training was all open, when I trained back in the 90s in thoracic, everything was done open for the most part. And I became very good at it. And patients, we had good results. And then I went through the process of learning to do videoscopic cancer operations, which there was a learning curve, and it was painful to learn. And you had to go slow and work your way up to doing it. And then the same thing for the robot. And I know we're going to talk in a while about the process of becoming a robotic surgeon. But I have to say that I would never go back to doing videoscopic cancer operations. I just enjoy the robot platform so much more. I think it's much more akin to doing it open. Except because these instruments are like having your hands and your wrists inside the chest, and you can do, in my opinion, much finer dissection, much better handling of the tissues, less bleeding, less tearing of things. It's very, very precise. So that's why I love the robotic.
And you started your surgical career before robotics was as popular as it is.
That's right.
So I'm curious, what drew you to, hey, this is something I need to get on top of because it's the wave of the future? And what was the initial reaction of the surgical world to, hey, robotics is the wave of the future?
Well, I think, as you and I were saying before we started this, there's never been an advance in medicine that wasn't made by a heretic. And in the sense that, every time someone says, well, why don't we try doing it this way? Everybody just says, that's crazy. We're not doing that. And then a year later, when that new technique is shown to be good, everybody claims, well, it was my idea. So that's just the way medicine is. And, when laparoscopic cholecystectomy first hit the scene, I was a resident at NYU. I remember very well thought of surgeons, very experienced surgeons, thinking that there wouldn't be enough room in the graveyards for all the patients. And look how wrong they were. A couple of years later, those same surgeons were leading, the so-called leading laparoscopic surgeons. So I think that, change comes hard in medicine because of the price of making mistakes. I mean, you're dealing with people and people's lives and people's health. So, I mean, it has to be a very, very sober process when you're making changes in techniques that work and that they're safe. Having done that, the answer to your question really is that, yes, I was trained as an open surgeon, but I did some laparoscopic or thoracoscopic work when I was a resident, just didn't do formal lobectomies. And as I started my practice, you see the way things are kind of going, and the market forces are very strong, and people look for that less invasive way of doing it. You kind of have to change with the times. If you stand still, you're going to get behind. So at some point, I just said, you know what? I know I'm going to have to do this, so let's just do it. I have confidence in my own abilities to learn, and adult learning is a very different ball game than trying to teach children, because most children don't assume they know everything, and so it's very hard to teach adults things, because you have a room full of surgeons trying to teach them something. They assume they know it already. So it's very hard to get them to change. I did, and I swallowed my pride, and I said, okay, I don't know really how to do this. And I went and I watched people do it, and I took courses on doing it, and then I had people proctor me, and we started slow with just small parts of the case, doing it that way, and then worked my way up just to make sure it was safe, because in the end, the only person taking the chance is the patient.
Right.
So, I like to sleep at night. So,
So can you tell us a little bit about what the process is? This is fascinating to somebody who's not in the medical field.
Yeah.
And to have a perception of what you see on TV or in a movie or something is probably very different than what you're actually doing in real life.
So for the robotics, it's actually the great thing about the robotics is that the robot actually kind of just positions itself. It used to be with the first iteration of the robot, which was called the SI robot. It didn't really do that, and it made it difficult. You could point the arms in one direction, and if you had to go in the other direction, it made it very difficult to do that. But this new robot for my procedures, it's very easy to set up. It's very user friendly, and what you do is you position the patient the same way you would position them for open operations. There are certain landmarks you use on the chest to find the interspace you want to work through. And the great thing about robotics, robotic thoracic surgery, is that you work through the same interspace. You're only in one interspace. The ports are spaced within that interspace, but in general, you're in one, maybe two interspaces. And that helps to minimize pain, because the pain after this type of surgery occurs from compression of the nerve that runs under each rib, called the intercostal nerve. So the more interspaces you're in, the more chances are the higher the chances you're going to injure more of those nerves, which regenerate, and in the vast majority of the people that pain goes away. But if you're in one interspace, you may injure one nerve, but that will be a lot less pain than injuring two nerves. But what you do is you set it up, you put your ports in, and then you choose what instruments you want. You put them in the ports, and then you connect them to the robot. Once you do that, the robot kind of sets itself up. It knows where your target anatomy is inside the chest. And then when you go to the console has has a controller for each hand. And when you move your wrist, the end of the instrument turns exactly the same way. So it's literally like having a small version of your hand in there, depending on what instrument you're using. And when you move your hand, the instrument moves. And the other great thing about the robot is that your optics are three-dimensional. When you put your head in that viewer, you're seeing the inside of the chest as though your head was actually inside the chest. You're seeing in 3 dimensions. So I can kind of see when I'm dissecting around one of the pulmonary arteries, which is a very frail structure with a lot of blood in it. I can see as things are coming around the back, I can visualize it's 3 dimensions. So it's really much more comfortable. I always used to say it would be interesting when I was doing VATS lobectomies, it would be interesting to study how much urinary stress hormone I generated during those operations, because a lot of times at the end of the case, I would take my scrubs off, and they would be drenched in sweat.
Wow!
So it could be a very nerve-wracking experience.
That was a great illustration of that. That's incredible.
I mean, you can go on YouTube and type in videoscopic or robotic lobectomy, and you can actually watch these things because they're all taped. There's video. I have videos of a lot of these things, and you can watch these things, and you see what the surgeon sees, and it's just fascinating.
That really is. So how do you determine nowadays which patient is a candidate for the robotic surgery versus old school surgery?
Well, I think, and it's funny that the indications and the contraindications for these procedures has gone through a whole gauntlet, just like for VATS. I mean, when I started doing VATS, anybody who had previous surgery, that was a contraindication for VATS. Well, that's no longer true.
Okay.
In fact, when patients have had previous surgery, and the reason for that, I should explain, is because when you have surgery, after the surgery, you develop what are called adhesions. Mm-hmm. So the tissues can be stuck inside the chest, like the lung might be stuck to the chest wall or might be stuck to other structures. So, the whole idea was, well, you can't do videoscopic surgery if they've had previous surgery because they have adhesions. Well, it turns out that the best way to take down adhesions is videoscopically. Yeah. So, because when you do it open, you really can't see in there. You make your open incision. You can put your hand in there and you can feel your way around, but that's not the greatest way to do things. Mm-hmm. So for robotics, I start out saying that everybody is a candidate for robotics. It's really the surgeon who decides that at the time of surgery. Mm-hmm. Now, I've had one patient in my experience that I remember that I put my port in, and everything was so stuck that I really couldn't get everything else in. Mm-hmm. And I wound up doing that patient videoscopically. I didn't have to open. But I've had patients where, in fact, we do what are called decortications robotically. Decortications are when patients have infections in the chest. It's not cancer, it's infection. They have empyema. People have probably heard that term. But that's basically it's an abscess in the pleural cavity. Mm-hmm. Everything gets very stuck, and the fluid in there becomes like oatmeal. Very, hard to get out. People used to say, well, you can't do those operations robotically. Well, yeah, you can, and I've done them, and there are a lot of guys out there doing them, and in fact, it's a great operation. It's a fantastic way to see all the planes because you want to get all that infected material off of the lung so that the lung will re-expand and fill the space. Mm-hmm. So that's what a decortication is, and it's actually a fantastic way of doing it. The indications are kind of fluid, if you will. And I think that a lot of times it depends on the surgeon's comfort and his experience. What I would say, I can't do this robotically, somebody with a few more years of experience than I have might be able to do it. Mm-hmm. So I think that as you get more and more experience, you feel much more comfortable doing these operations. So for the short answer to your question is I don't think anybody is contraindicated for robotics, but you may have to back off once you get in there for one reason or another. Yeah.
And you talked about earlier how the medical field was originally hesitant or resistant to robotics. I imagine that there are patients that the thought of a robot working on them is like something that frightens them. How do you reassure them that this is safe, this is the best way to go?
Well, I mean, I tell them that, the robot's not doing the work. If I walk out of the room, the robot's not going to do anything. So it's me doing the work,
Right.
using the robot as an extension of my arms. So and it allows my arms to shrink down to 8 millimeters in size, which is what the size of the ports. Most of the ports that we use are 8 or either. Some of them are 12 millimeters. But 12 millimeters, that's 1.2 centimeters. That's less. That's roughly a half an inch.
Wow.
So as opposed to me putting my mid in there, which is much bigger. The robot's not actually doing anything that it's not told to do. So I mean, you could say, how do you get to the store? How does your car drive to the store? Now there are self-driving cars,
Right.
but the car's not doing anything you're not telling it to do.
Right.
So this is just a platform that allows the surgeon to do what he would normally do in a much more minimally invasive fashion.
And with most of RUMC's surgical staff trained in robotics, about 80% of the staff is trained.
Yes.
As the chair of surgery, when you're interviewing new candidates, is that something you look for when you're looking at candidates to expand the department?
Yeah, absolutely. And I think that for me to say that, robotics is here, but, it's not going to be that important in the future, that'd be crazy. I tell my residents quite frequently, probably too frequently, that, the way you're doing surgery now will not be the way you're doing surgery 10 years from now. And that's a good thing, okay, because we're evolving. And I think that evolution is not only important, but it leads to better outcomes for patients. And look, people who are having surgery are scared. They're all scared. And honestly, I think a lot of surgeons are scared when they operate. Lawrence Taylor once said, if you're not nervous before the game, you shouldn't be playing. And I get nervous before every operation. I go to YouTube, I look at videos, I review anatomy books before every operation. My wife always knows when I have an operation offset, because I'm sitting there and I just say, no, not now. Don't bother me now. Because it's important. That's what I would want my surgeon doing. Nobody treats this like they're going fishing. It's not the same thing. But yes, I think it's very important that the surgeons I'm hiring, especially the younger surgeons, have robotic experience, and most of them do. They're looking for it because they understand, and medical students are looking for it when they take residencies, because they understand that this is the wave of the future. You will not be able to go through a general surgery residency and not have and go out and practice without some minimally invasive at minimum, but certainly robotics experience.
But lifelong learners too.
Well, that's why they call it a practice. And I think that every day, believe me, I learn something every day. There's no such thing, in my opinion, there's no such thing as an expert in surgery. There's nobody who knows everything about surgery. The exciting thing about being a surgeon is that you learn new things every day. And no two patients are the same, no two operations are the same. And that's why I think that reviewing the anatomy, because you'll see, abnormal anatomy. You'll see, I know how many arteries there are to this lobectomy, but sometimes you'll see extra ones. Sometimes you won't see as many as you expect. So you have to have a basic knowledge, but you have to be willing to say to yourself, I don't know everything, and I'm willing to learn. And I've had patients, I've been doing this 26 years, and there are still cases that I've called people that trained me, and I said to them, this is the case I have. I'm not sure what's going on here. What do you think? It's important to know when you need to ask for help. So it can be a very humbling business.
Oh, I can imagine.
Yeah.
And with technology advancing every day,
Yeah.
what do you think is the future for robotic surgery? Do you think that robotics will eventually be able to be performed, autonomously without?
Well, I hope not. If you had asked me that about cars driving themselves 10 years ago, I would have said that's nuts. But now we're seeing it. So I don't know what the future holds. I know that there'll be better instruments, better platforms, even smaller robotic footprints for the machine itself, better technology in terms of we use electrocautery in the operating room, better types of current, other things that are less injurious to tissues. All those things are going to be good things. I hesitate to say it, but I'm hoping that it won't be something where you don't need the surgeon in the room.
Yeah.
There is that something special between the surgeon and the patient.
Absolutely.
And like during COVID, I never did telemedicine during COVID. I refuse to operate on anybody I haven't actually met and put my hands on.
Great.
I think that was a bad practice. So I enjoyed. That's why I went into medicine, because I enjoy that interacting with my patients. So I hope not.
I agree. Well, I'd like to thank you again for
thank you.
joining us today
Thank
and
you.
for all that you do to keep us safe and well.
Well, thank you. Appreciate it.